What are the greatest advances that you've seen as far as supportive care, drugs, and other modalities?
Well, interestingly, one of the things that we've made the most impact on in the last 10 to 15 years is actually the nausea and vomiting drugs. I remember as a resident when I first started in the oncology program that women with breast cancer who were having adjuvant treatment to cure their disease would come into the hospital, we'd put the drip in, we'd give them drugs to make them unconscious because they hated the vomiting, they'd vomit for 24 hours and then they'd wake up and they'd go home. And then overnight, when the 5-HT3 antagonists, the cetrons came in, that stopped. But it wasn't just because of those drugs, it was because we learned how to use the other drugs better. So it's not always the new drug, it's learning how to use all of the drugs that you have that makes things better. So that's one of the highlights.
As we move into this era of more and more targeted therapies, molecular-based compounds, what are the unique side effects that are now on the radar screen that you didn't have to deal with 20 years ago?
Well, that's a very pertinent question. I've just been chairing a session on the toxicities of targeted therapies. This is a new area that we are going to have to take much more seriously. The 3 toxicities that we discussed this afternoon were skin toxicity, gastrointestinal toxicity, diarrhea, and heart toxicity. And those are the big 3.
Right.
Heart toxicity including high blood pressure as well as cardiac dysfunction. So those are serious toxicities that, again, I was talking about how we need to invent an equation that I haven't invented yet, but I'm threatening to, that combines the number of patients that are given the treatment with the duration of the treatment, because these targeted agents are taken for months and years sometimes, with the effect on quality of life of the severity of the toxicity, to come up with a measure that can tell you how bad it is. Because with the number of patients that we'll be treating and the length of time, even a small amount of diarrhea for a year would be miserable.
And I'm assuming that there are more and more drugs becoming available to help patients use prophylactically before some of the toxicities set in.
Well, you would think so, but the problem is that we don't always know why people are getting the toxicities, because if they're unexpected, they're not expected when the drug's developed, then you don't have a plan in place. The other problem with the targeted therapy is that it's the same pathway in the cell that's causing the toxicity as is curing the cancer. And so you've got to work out how to stop the toxicity without stopping the cancer effect.
So some of the easier ones of one's white count, that you can treat someone to hopefully avoid that major drop in white count. So it all depends, I imagine, what toxicity you're talking about, whether you can do some kind of prophylactic intervention versus the treatment.
That's exactly right. And it sounds odd to say that the blood system is straightforward, but it is very predictable how those cells will develop, and you can therefore intervene with a single drug at a specific time to change the way that develops. With the gut, it's much more complex. With the skin, it's more complicated, and so those toxicities are harder to fix. But research is going on in those areas, and I think in the next few years we will be testing all the new drugs in the models that we have of these toxicities, and then testing all the things that might be able to prevent or treat.
Your work with MASCC is so critically important, and it was interesting, if you don't mind sharing, what it was like for you as a medical oncologist who decided to branch out into an area that probably made you feel like, well, am I stepping away from hard science?
That is very interesting, and it does make me laugh quite often, that when I first started doing research into supportive care, people were a little bit funny about it. It wasn't mainstream curing cancer research. And I was always a little bit embarrassed to say I'm a supportive care researcher, because in some ways I was looked down on for doing that sort of research. But I have a very successful laboratory, I have a very successful clinical trials program. It's been wonderful for my career. MASCC has been the most important of the professional organisations to which I belong. And it's actually really important. It's not side issue, it's actually mainstream. We say in MASCC that supportive care enables excellent cancer care. You can't cure cancer without us, because unless we minimise the toxicity for patients, they're not going to get through the treatment. In this era of personalised cancer medicine, everyone focuses on the patient and the tumour, and we're coming along saying, and the toxicity. You have to personalise the toxicity management as well as the anti-cancer management to get the optimum outcome. And so I'm not embarrassed about being a supportive care researcher anymore. I think it's absolutely vital.
You think when patients have this discussion with their doctors, they actually need to be the ones to bring up at this point, I'm concerned about the toxicity and I want to know what every side effect that you know of might be and how we would manage my care should those issues present?
That's a very interesting question. I think it's a shame that the patient should have to be the one that raises the question of toxicity, but I do think that advocacy works. And so, yes, if the patients are worried about it, it is part of our duty to be telling them about the toxicities. Although, again, when I discuss toxicity with my patients, I say to them, it's compulsory for me to tell you what all the toxicities are. Mm-hmm. It's not compulsory for you to get them all, because, of course, we can't predict who's going to get them the first round of chemotherapy. But we know that by the time they have the second or third, they'll be telling me what toxicities they'll have. So, yes, it does need to be discussed, but in a way that doesn't terrify people. Because sometimes if you tell people too much, you actually put them off having the treatment at all, which is not the idea.
You've been with the organization 3 months.
As the president, yes.
So, yes, as the president, and I'm hoping that what happens is we can do something to bring the advocate community together around and the patient community to support your efforts.
There are two things that I'd like to say. Firstly, I think it's time that MASCC became a partner with the patients in the future of supportive care, and we're hoping that in the next couple of years during my presidency that we can have our first MASCC Patient Supportive Care Seminar, where we would like to have some of our experts give their expert lecture, but not as a scientific lecture to other clinical people, rather as a lecture to the patients, with a short lecture followed by a large amount of discussion time, so that we can actually learn from the patients what they would like us to do. My other thing that I'd like to emphasise is this business of the oral therapies, and how, again, this whole idea has grown up that taking a tablet is better than having an injection. And of course the side effects are not necessarily less bad, and we need to spend some time as clinicians making sure we're monitoring and caring for the patients who are on oral therapies as well as we do for intravenous, and make sure that the people prescribing these drugs really understand their impact fully, because there's an ability sometimes for non-oncology specialists to be using these drugs but not understanding the holistic nature of their management.
And recognizing the supportive care needs of patients will, one, enable patients to commit to their therapy, oral therapies, to make sure they're taking their drugs, and to feel that there's a refined partnership with their doctors to get them through treatment to ensure quality of life.
Absolutely.
Professor Dorothy Keefe, welcome to your position as president of MASCC. Very long name, Multinational Association of Supportive Care in Cancer.
Thank you very much indeed. It's the supportive care bit that's the important bit of that long name, and that we should keep in mind.